Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I am your host, Rebecca Sapp. I am a board-certified allergist and immunologist with a focus on medical education, and I always enjoy learning more about the exciting field of allergy and immunology. Our podcast series will use interviews with thought leaders from the world of allergy and immunology to keep you up to date on new developments and to review core topics. Today's edition of our Conversations from the World of Allergy podcast series will focus on the topic of genetic testing and immune deficiency. We are pleased to welcome Dr. Sarah Henrickson. Dr. Henrickson is an assistant professor in pediatrics at the University of Pennsylvania and at the Children's Hospital of Philadelphia. Her work focuses on T-cell dysfunction and chronic inflammation and inborn errors of immunity. Dr. Henrickson, thank you so much for taking the time to join us today.
Thank you so much for having me.
I'd like to start just by getting to know you a little better. Can you tell us a little bit about yourself and include something you like to do outside of medicine?
Absolutely. So I'm an assistant professor at the Children's Hospital of Philadelphia and University of Pennsylvania, and I see pediatric immune deficiency patients, and I run a lab, as you said, studying immune dysregulation. Outside of the hospital, I'm married and have two kids, one of whom's applying to college this year, and we all really enjoy hiking in South Jersey.
That's awesome. Are there great places to hike in South Jersey?
Not if you're looking for elevation. We don't really have mountains, but we have lots of, we have the Pine Barrens. So there's a lot of kind of pine swamp based, really sort of fun terrain, but very much flat. So it's more, I guess walking is a more, more fair way to describe it.
Fair enough. So good walks in that area. Perfect.
Yes,
Well,
yes, exactly.
what made you interested in the field of allergy and immunology in the first place? What got you in?
That's a great question. I've always found immunology interesting. And my PhD had been in really basic understanding of how cells work. And even before that, in undergrad, it was the first advanced class I took that you could really hear about kind of the frontiers of science and medicine at once. And I had a fantastic professor. The frontiers of medicine are very real, and that science is a strategy to push those frontiers forward and both together for my own career, being able to bring together seeing folks in clinic and then being able to walk to the lab and study new and old diseases and new and old questions, for me lets me put together both the looking forward piece and the taking care of patients right now piece. So I find that really fulfilling.
Yeah, especially the world of immune deficiency, or now we're calling it inborn errors of immunity, to really
Yes.
capture the genetic underlyings of this. As you look back over kind of the start of your career and now this lab that you've developed, what has changed in the field?
Oh my gosh, so much. I mean, I think for our field, one of the reasons we're now such a genetics forward field, I think, was the inclusion with a tremendous amount of advocacy from patients and providers and legislatures to get newborn screening for severe combined immune deficiency to be a part of our practice. I think, and that was really when I was, for my own training path, that was sort of between when I was in med school through fellowship, that really became new and exciting to being sort of normal and expected. And the piece where our specialty was suddenly meeting healthy patients and needing to think about how to transplant and if to transplant, and then getting comfortable with sequencing in that zone, and then realizing, there are so many other complicated diseases and patients that we take care of. We can take these new skills that we've learned and apply them across our field. I think that sort of genetic frame, which was very much fundamental to my training, and I think for folks that have come since that time is just sort of built in and seems expected, was a huge shift for, instead of thinking phenotype first, I think the humbling reality of genetics that we didn't understand how broad phenotypes could be, and that it's neither one gene nor one phenotype, nor one phenotype, one gene, that we really have to learn from our patients and put that together with the genetics and all the other kinds of testing. I think that's the biggest change from my perspective, is that we, especially in the last sort of 10 years of training, have become such a genetically informed specialty, with tremendous benefits for patients and targeted therapy, but a tremendous responsibility for learning and training.
I remember when the genetic screening really became a part of our repertoire. I was in fellowship as well, and seeing those graphs where if you could transplant before 3 months in these severe combined immunodeficiency patients, they did so much better. And now here we had this opportunity to catch them before they were ill. It was just really an amazing time.
Absolutely. And I think now that we're with the most recent list of monogenic inborn errors of immunity, at about 550 diseases for 505 genes, there's just such a wealth and breadth for our field, and the amount of sort of learning and keeping a track of things, and both from a research perspective and a being able to take care of patients perspective, there's so much to know and so much to discover. So it's a lot for our fellows and for our fellows to learn and our providers to stay on top of. But such an exciting time for our field.
So, speaking of which, what is your approach to genetic testing in these patients that come to you with where you suspect or you've diagnosed an inborn error of immunity? What are the patients that you're sending for genetic testing?
That's a great question. As a pediatric immunologist, I do think that the pediatricians in immune deficiency are probably even more prone to use genetic testing for a lot of reasons. Partially, I think because we've been taught by our newborn screening programs how to use and to have a comfort with genetic testing. In terms of who I refer, there's a lot of ways of thinking about this. The way I think about it is our clinically approved testing is really, really good at detecting amounts. Do you have enough cells of the right kinds? Do you have enough antibodies? And is the general frame of the quality of those antibodies appropriate? I think beyond that, when we get to people who are dealing with autoimmunity and infections or lymphoproliferation, and those things are normal or not that different, and we're thinking about the function rather than the presence of the parts of the immune system, that's when I think of genetics as almost a functional test. Because we really, although there's amazing pioneers like Roshni Abraham who are building new tests, there's a dearth of CLIA-approved functional tests in our field compared to many other specialties of medicine. And since so many of our diseases are genetic, I think a lot of us where we're seeing immune dysregulation and differences in function that aren't explained by our enumeration, our counting up tests, turn to genetics as sort of a next level, especially with panel testing. It's so much cheaper than many of the things we do without thinking. Almost any situation, a genetic panel is going to be cheaper than a flow cytometry panel, and it has the capacity to teach us so many things, not in isolation. But I think I tend to reach fairly early where I have questions around function. So if it's really severe infections that are unusual, if it's a course for specific antibody that doesn't make sense to me, or where there's a lot of autoimmunity in the family, common variable with any sort of non-infectious complication or very young, and any of the combined immune deficiencies, any of the primary immune regulatory pictures, I'm proposing it to families. Of course, it's a shared decision-making model if folks are interested and to receive genetic testing and what type they're comfortable with. And then if they are, then there's the insurance question that you raised, how do we make this possible for families? But it is something I reach for as a tool fairly early.
It's a good reminder that it actually cost wise, there's a benefit to it that we don't think of it being a bit less expensive than something like flow cytometry, which we do quite frequently. It's a good
Yeah, I think
reminder.
Yeah, and I think it is something that it seems, I think in our conversations with insurance, that can also be helpful to remind them. The earlier conversations looking back in time were more about, well, is it experimental or is it clinical? And that conversation has pretty much been closed. And there's lots of great position papers, including working group reports from Quad AI and from CIS to help support discussions when that is the perspective of the insurance company. But I think around, is it worth it from an insurance company perspective? It really, for panel testing, is a quite efficient use of resources given how many diseases we get some insight into with that type of testing. No test is perfect, but it can be a very efficient use of resources.
How do you bring it up with patients? So you have a patient that you think would benefit from genetic testing, whether a pediatric patient or an adult patient. How do you start to have that conversation with families?
That's a great question. I think primary immune deficiency and inborn error of immunity clinic visits are often longer. And one of the parts of those visits that is never ever can never be skipped is family history. And so I think that's one piece where it's a natural transition. Another piece is we always go through the infections that the individual has had. We always go through, any signs of atopy, any signs of autoimmunity in the patient or in the family. And I think at the end of kind of going through exhaustively in the review of systems, families have a sense that you have thought about everything you can think about with them. And if there's data, if this is the first immunology visit that they've ever had, or if there's lab data, if this is the first immunology visit that someone's ever had, it comes, whether I bring up genetics depends on whether I think there's likely going to be a role for that in the future or whether that needs to happen. I think that needs to happen sooner. So there's a combination of the severity of the symptoms. Am I inpatient in the PICU? Am I in clinic? But if we assume I'm in clinic, if there's been a frequency of infections or a coalescence of symptoms that I feel like, and the family agrees that moving quickly makes sense, sometimes it makes sense to send genetics as the second stage, or especially if someone has already done the screening immune testing with the enumerating flow and the humoral evaluation inpatient or at a PCP's office, then it may be something we do talk about and even complete on the first visit. But usually the first visit is more about understanding and doing some initial testing. Um, and then I will often mention for many patients that this might help us in the future, but it's not where we are right now. And we'll do this first pass evaluation, and I give them a metaphor for why genetics is being mentioned earlier in my clinic than it might be, in the pulmonologist clinic or in another specialist clinic or the PCP's office. And I usually use an analogy of a cookbook for genetic testing, and that, like any recipe, we have a cookbook that tells us in each cell, that tells us all the things that cell could be and could do. And so when we talk about gene testing, there can be missing chapters, there can be extra pages, but and that level of genetic testing, when those kinds of differences are there in the cookbook, that it's often very obvious and there's multiple systems that are affected early. But as someone seeing an immunologist in a clinic, most often what we're thinking about is looking for much more subtle differences. And we talk about it's more like looking for like spell checking. We're looking for words being misspelled or sentences having, a word that's extra here or there. And there's that scale among the 3 billion bases of one or two bases alone is enough to create a large disease. And that again, in our field, we don't have as many tests of how the system works. And so for us, genetics can be that test. And if it's an urgent or severe patient, then I would talk about, why don't we go ahead and work on getting insurance approval now? That's fairly unusual. But for many of my patients, it might be the next thing I suggest after the first or second round of blood testing, depending again on infection frequency, types of bugs, and almost always in anybody who has non-infectious complications that are more immune dysregulatory, like autoimmunity or lymphoproliferation, would I be thinking about genetics earlier? But I try to introduce it as a possibility on the early side to facilitate later conversations should they be needed.
I like the analogy of the recipe book that, we're looking sometimes for, rather than a teaspoon, maybe you got a tablespoon. And that small difference in the recipe can make an enormous difference in the outcome.
I love that. I'm going to use that. That's awesome.
And what concerns have patients brought up to you when you start talking about genetic testing, especially maybe a parent with a young child? What kind of concerns have you heard from your patients?
Yeah, great question. Um, there's concerns. Part of it is understanding what someone's background is in sort of biology and genetics, and if they understand what we're talking about. There can be concerns if someone's not as familiar with genetic testing as to whether we're going to change their child or whether we're going to do something that could have, that could impact their child directly. And so clarifying that this is understanding, not an intervention. For families who, so that's an important part of the conversation for some folks and can be really helpful. I think with regard to genetic testing, there's also the concern that it will reveal something about the parents, who may or may not be interested in having their own genetic testing. And that's, we, clarify that that's a choice that each parent would get to make and only relevant for exome testing or genome testing. And if it's a question about genetics of the individual patient on their own, taking away some of those other issues, we talk about, there's many things people think about. One is, what if we find nothing? So we don't understand still. What if we find something that's scary? And what if we find something confusing? And that's usually how I've been the possibilities. We may find nothing, which may mean that there's still a genetic difference we're not identifying, but we may not find it with this test. So we try really hard. I got the wonderful word from someone else to use the word non-diagnostic. I think it was Kate Sullivan in our division, as opposed to negative, or that it's, that it's normal. We can only know as much as we know right now. So non-diagnostic is a great word if there's no result that helps you understand the situation. And then the finding a change in a gene that's already been proven to cause a disease that looks like your patient's disease, that's fairly straightforward. But I do spend a lot of time with folks talking about there's a decent chance we'll end up in a gray area where we get an answer and we don't know if it affects their patient's health, that a change in the gene, in the DNA of the gene may not have any effect on how their body works. And that unfortunately, we may not have a test to be sure if that's true or not. And so that one often families don't know to be worried about, but I'm most worried about that for them, that I'm going to deliver more confusion and more stress, especially with panel testing, but also with exomes. And so the idea of the variant of unknown significance, which is why I think at QuadAI and CIS and a lot of our meetings, the concern about how do you handle genetic results is such an important one. I think people are appropriately concerned about that. But families come down more often on, what will we learn that we aren't ready to hear, or how much will it cost? But once we start talking about the fact that we may tell them something that we can't provide clarity, then that sort of gives them a new concern.
So you've talked about panel testing. Maybe
Mhm.
you could describe the different types of testing. So
Absolutely.
starting with exactly what we mean by panel testing, and then
Yeah.
exome sequencing, genome sequencing.
Yeah, absolutely. One of the things we do in our fellowship it's probably the same as every fellowship, is we teach our fellows. And so when I started giving these talks, not that many years ago, it was still quite normal to do single gene testing for things like BTK, for X-linked agamoglobulinemia. By and large, single gene testing is no longer that useful. By and large, most genetic testing that we're all doing is using something called next generation sequencing. And that's a big fancy word that basically just means we take whatever the DNA is, we chop it up into tiny, tiny pieces. We trap those tiny, tiny pieces. We use various fancy ways to sequence them. And then a lot of next generation sequencing is the math and genetics of putting tiny pieces together and building genes, and then looking at those genes and figuring out if they have differences in sequence from what we consider normal or don't. And if there are differences in sequence, how to think about those. So if that's the backbone of the how, the ways that we use that are either what we call panel testing. So panel testing is the idea that we don't want to test all the genes. It makes more sense in some situations to test a subset of genes, and you try to put together lists for clinical scenarios. So for example, there are a number of different companies that make lists um, that reflect inborn errors of immunity. And it is challenging for those lists to keep up with the discoveries in the field. And so the different companies update their lists with different frequency and don't have the same genes on them necessarily. So it is important to be a good consumer. But generally, the idea is that there's a list that generally ends up being something like the Immunological Union of, no, sorry, the International Union of Immunological Sciences. And that list is about what many of the gene panels look like. So they're 400 to 500 plus genes. And you're only looking for variance differences in those genes, and no other genetic difference would be detected. So you can only get an answer to the question you're asking. So we're asking what the sequence is for those genes. And it doesn't matter if the disease that gene is known to cause looks nothing like what your patient has. There's no filtering for the phenotype of your patient or the labs of your patient or anything about your patient. It's just everything that's different. And there's no comparison to parent either. So that's a gene panel. And then a whole exome is named because if we go back to biology, the way that you make the way that you take DNA to mRNA to protein, you have introns and exons. And so you get rid of the introns and splice them out. You put together the exons. And so an exome is named because it's the DNA of the exons. So you're getting 1% of all the DNA is being sequenced. And so that gives you, and because of the way it's done, you miss any gene variant in an intron, you miss anything between genes. And there's some genes that are tough to sequence, and so it doesn't cover those perfectly either. So again, no test is perfect. The goal is to hit the exons of our genes, and then a genome, the goal is to hit all the sequence, to get all 3 billion bases sequenced. And again, they're all essentially on the same technology backbone. It's kind of what they're reporting out to us.
The first time I ordered a gene panel, I think there were right at 100, and now it's amazing that it doesn't feel like that long ago. Now we're upwards of 500. It really is incredible. And one of the reasons
Yes.
why you tell patients we're learning every day more and more, and it may be then in 10 years we have thousands of genes that we can really know are important in the immune evaluation. So I feel like just that increase in availability explains to patients why we don't see things sometimes, but maybe in the future.
Yeah, and I think that gets to the point that for our bigger tests, our genome-wide tests, whether they're exomes or genomes, I always try to talk to families about the fact that even if it's non-diagnostic today, so there isn't a difference in the DNA today, that is either there's nothing on the report, or the things on the report are variants of unknown significance that we don't think connect to their family, to the patient's medical health. It's really important to think about going back and reanalyzing that data. So same raw data, no new blood draw, which is usually a great thing for families and patients, of course. For a certain period of time, we can go back to that old data and reanalyze it with new science. And so every couple years, it's worth thinking about whether that would be valuable, especially if the patient's phenotype has changed, if there's new diagnoses, new medical history to take into account that would change the way you think about the old data, or simply the passage of time and new diseases have been discovered that would help us better understand that old data. There was a certain point at which some companies would want to rerun it with new technology, but often you can go back for quite a while to the old data that was already drawn.
How is the test done logistically for patients? What can they expect? Kind of the timing and the results that come back.
It's a great question. I think there's actually quite a bit of variability, but in broad strokes, it can always be done as a blood test, and that can be challenging for folks. If it's feasible, though, it can always be drawn from blood, and that means the white blood cells in the blood sample are going to be used for the testing. There are many companies that will receive a cheek swab for panel testing or genome-wide testing. And that can often be sent to the family's home, and then they can mail it directly to the company. And there are also some locations that will allow saliva testing, although it can be quite a bit of saliva. And then there are sometimes times when, and this is very unusual and would be for specific reasons, more often research, that a skin sample can be looked at if there might be a difference between the blood and the skin. And again, that would be in very specific situations. So a sample is taken, and then it's sent to the company, and it depends on the scale of the testing, how long it takes to come back, or if there's been extra urgency added to the test, it can be much faster. So in general, and there's variability lab to lab, so I definitely don't pretend to be, I can estimate. I would say gene panel testing is on the order of a few weeks generally, but that can be variable to be a little bit longer and different from facility to facility. And then exomes are generally more on the scale of months. They can be a couple months, they can be 5 or 6 months if a place is backed up, but would hopefully not be that long. And genomes are about the same. However, most companies will offer a rapid version, which has to be approved differently, and it's usually only used in the settings of like ICU admitted patients, for example, for a rapid exome, or I think there's also rapid genome options, but definitely rapid exomes are available at many institutions and companies that provide that service. And then for obviously an extra fee, it can be faster, and that's often more like a week.
I think it's good to remember that when we talk to patients about it, that we are talking weeks and not that you're going to have the results in a couple of days. And so they kind of have that idea of scale that they're looking at.
Absolutely. And I think also it's one of those tests, it's not like a CBC or an IgG where we can receive the test and immediately process it ourselves and then call and have an answer. And I think that's also can be a real source of frustration. And expectation setting is so important, as you point out. I think it's also really important to say, I'm going to get the results back and I'm probably going to have to think about them. I can give you a very if there's no findings and it's non-diagnostic, I can tell you that quickly. But in most cases, there will be something for me to think about, and it will take me a little bit of time to process before I can go through it with you in a way that's going to be most helpful to your family. But I think that that piece is also not always anticipated, that it's not that we're getting the answer, we're getting information. But almost always that information is going to require you as the provider to really think it through. And you may need to phone a friend or a couple friends and think about what your next steps are before it's useful for you to come back to the family. And I think to your point before around what do people talk about, I think there's some families, and like, when does genetics come up? Some families want to know everything, and they want to know it immediately. Some folks would rather not know anything more than they have to. And some folks really benefit from a a path that has increments to it that are logical, and people are different in how they're looking for information and process information. And so I think both genetics fits in differently for different families, and some families not at all. And I think for providers as well, it's important to learn how you process that information and how you best feed it back. Do you want to do that on a phone call? Do you have a genetic counselor you work with? Do you want to always set up a follow-up visit to talk about the results, no matter what they are, so that you're not, so that the scheduling of the visit isn't frightening, that there was always going to be a visit to talk about this, and therefore, that's just the way it is. And then the challenges with logistics with each of those models as well.
I think it can be very helpful to speak to the patient, whether that's in person or on a virtual visit, but to actually have that conversation, because the
Yes.
information that they get back, trying to understand it can be hard as a clinician who reads them, let alone as someone who is worried about their own health or their child's health. And what am I going to do with this information?
Absolutely.
Now, you mentioned these variants of unknown significance. Can you tell us a little bit about what that means and what you do with that information?
Yeah, absolutely. So I think if you think about, so you've met a patient, you were concerned for an inborn error, you did phenotype and functional testing as you thought appropriate, and it led you to get genetics because of your concern for either a new in this person or something traveling through the family that was an inborn error of immunity. You obtained your testing by either panel or exome or genome, and it came back with a report. And so the report can say non-diagnostic, as we talked about, and then at that point you talk if it's a genome or exome, when would we look at the results again? But otherwise, you are where you are, and you can think about whether a negative exome, you can consider a genome, a negative panel, you can consider an exome. But we put a hold on that. The opposite end of the spectrum is you found a gene that's known to cause an immune disease, and you found you found a gene that can cause a human disease, and the variant that your patient has been published to cause that disease, and the phenotype of the disease matches your patient. If all of that goes together, then you move forward and you talk about prognosis and you talk about therapy, and you're moving ahead with that piece. In the middle, there's two options. One is the report mentions, and I wish I could remember who told me this turn of phrase, a gene of unknown significance. So this gene has actually never been directly tied to human disease, but it's either on the panel because it's thought to be likely, or it's on an exome, and they think that the either mouse data or sort of hints in silico or in publications are enough to put it in the clinical report. And then you're not only thinking, well, does this change in the gene matter? You're thinking, is it this gene at all? And I think the idea of separating that from the second option, which is there's a gene that causes human disease, and that's been shown, human immune disease, but the variant you have specifically has not been published or hasn't been published with enough evidence that it's been considered pathogenic. In either case, you have a gene with a mutation and you're trying to figure out if it has anything to do with your patient's health. So while they're different, I think you can think about them together. There's a number of different things you can think about. In a gene that's been published to cause human disease, it's incredibly helpful to read the papers. And the nice thing about the reports is they will link you to those. If you have one copy of a known pathogenic variant, like something that can cause disease, but you need to have two copies for disease, then you're a carrier, and that's a set of counseling that needs to happen, but it does not explain the disease in your patient. If it is a difference in the DNA that's never been shown before, you've read the paper and you've looked at the variant. The first thing I would do is go to a website that NIH runs called ClinVar, and you basically just type in the gene, CLINVAR, like clinical variant. You type in the gene and it just lists every single variant anyone's ever reported. And it'll tell you if there's a paper to give you evidence or if there's not a paper. And every time the clinical companies report variants, they put it there too. But that's just saying we saw this. It doesn't mean it's actually important for how the protein works. So you can see if there's a paper. The other thing you can do as a resource that's free is something called franklin.geneox.com. So like benfranklin.geneox.com. Same thing, you can type in your gene and your variant and get a lot of information about in silico estimates of whether that variant might change the protein. And it puts together a bunch of them, which can be helpful. None of those is perfect altogether. They're not perfect, but they can give you some information. It'll also pull together papers that have to do with the disease, and if the variant has ever been published, what that information looks like. And you can take that and the understanding of the disease that the patient might have, and I will often, if I really think it's potentially a good match, I'll do one of two things. One will be, is there a clinical CLIA-approved test of that pathway? Can I test for the amount of the protein? Can I test for the pathway that the protein interacts with? For example, if you have a mutation in CARD11, there's the potential that that could affect NF-kappa B signaling. And so could you look at some of the tests that exist around NF-kappa B function to help you understand that better? Or you can reach out to the last author of the paper that discovered the disease and ask that person if they have an in vitro test. Like, have you seen this variant? Because it turns out we talk to each other a lot and not everything gets published. So maybe they've seen the variant, even if they didn't have a chance to publish it. And you can ask that person, hey, do you have a research test my patient might be able to benefit from? Or do you have any insight into this variant? And if that's not the case, and none of that has worked, but you really think it could be important for your patient, you could consider whether to sort of phone a friend and think about research studies if your patient is interested in that. And I think the equity and access issues around follow-up for complex genetic testing results are really challenging. You need someone who has access to a lab and the ability to assist you in this way. But that's, if you're continuing to walk out those questions, that would be sort of the last step, is whether there's research studies.
I have been always so humbled at how responsive people are when you reach out to them with
Oh
these
my gosh,
questions.
yeah.
You know, these are people that study this, that think about this, and you reach out to them with a clinical case, and they're so excited to kind of help you think through. And so I would definitely encourage people who come up with a sequence to say, huh, you know, could this be meaningful for my patient? And they really have that option to reach out and get that expert opinion.
Yeah, and I think even for folks who aren't members of the Clinical Immunology Society, there is a listserv that you can send messages to if you have questions about a clinical scenario with or without genetics. So there's lots of ways of phoning a friend, but phoning a friend with genetic results, it's often most effective to talk to people who are studying the disease or discovered the disease. But again, CIS is another great way of reaching out to folks who may have more experience with the disease if it's not one, or the gene if it's not one you've worked with before.
Do you have any example where genetic testing has really changed your care of a patient? I'm sure you have lots of examples, but could you give us an example maybe where you found something that really changed how you approached your patient?
Yeah, absolutely. You're right, there's so many. So I'll give you an example. I had a patient, and I'll anonymize the parameters of what we're talking about. I had a patient who had a history of initially recurrent infections and then was diagnosed with specific antibody deficiency, and also had severe asthma, but was doing okay on azithromycin. And we were just following IgG, IgI, IgM, and vaccine responses over time. And then his IgG suddenly dropped and stayed low for a few months. And there developed a new family history of autoimmunity. And so I would argue at that point, almost as a fairly soft call, I sent genetic testing, and the genetic testing came back with a mutation in SH2D1A, which is the gene that codes for SAP. And the deficiency of SAP encodes XLP, X-linked lymphoproliferative syndrome. And we went through from there, and is usually a disease that's found when patients are very ill, often dealing with something like HLH in the setting of an EBV infection. But this patient was doing very well and was in school age. And so we went through functional testing to try to understand if this variant of unknown significance was relevant for my patient. And that testing gave us some insight. And for this particular individual, we actually went forward with research testing as well, which cannot be used for clinical decision making, but helped us understand sort of the context of this new variant. But it was really the clinical testing and his overall clinical picture that we put together with a lot of shared decision making with the family, and led to transplant for the patient. And it was definitely not the gene I was looking for this patient. It wasn't what I expected, is what I mean by that. But it led to a very different outcome for the family. And unfortunately, it's one of those diseases that is most often discovered in extremis in the PICU. So I feel like a lot of genetic testing for me has been teaching me to be humble in my understanding of what phenotype can be connected to which genetic disease, and being open to um, learning from the testing and learning from our patients as to how the diseases really work.
Yeah, so in that case, you're really able to catch a disease before it got to the point where the patient was really sick and probably really changed the course of his history.
Yes, and I think it's, so that's, again, I think it's one of those things that can give us so much insight. And if we counsel our families and they're open to it and we think there's indication, it really can change people's lives. It definitely also has an important role when people are that sick, understanding what it is that's going on in the patient with HLH. Though, of course, we treat the patient in front of us, it can give us context in the very sick as well. But it's wonderful when we can find a disease before it's become symptomatic and can intervene.
Do you work with a genetic counselor?
That's a great question. We at our institution at the Children's Hospital of Philadelphia, we have a close collaboration with our genetics team. So for some of our genetic testing, for most of our genetic testing, it goes through the genetics department. So they'll actually see a geneticist with a genetic counselor, and when the tests come back, we'll counsel sort of between the two groups, between immunology and genetics. And so that's one way of collaborating directly with genetic counselor. We have a multidisciplinary clinic, the dysregulated immune response team, and that has many specialties, including immunology and rheumatology and GI and neurology and infectious disease, as well as genetics. And in that integrated clinic, there's a lot of genetic testing that's ordered, and so that person is able to support counseling of those patients as well. But often we are ordering testing or interpreting testing as individual providers. We can always reach out for collaboration with genetics if that's not how the testing was ordered. So I guess I would say we have multiple models, but I find it incredibly helpful to have a genetic counselor involved, especially one of the things that a family can choose with whole exome sequencing is to get results for the parents and the child for a set of findings that we know to cause genetic disease that are outside immunology. And those I don't feel qualified to counsel. So I think if folks are receiving incidental findings, or if there are many scenarios where I've been incredibly glad to have a genetic counselor involved. And I think different institutions build clinics differently. Folks in private practice would almost never have access to genetic counseling. And so I think one of the roles of the Quad AI and CIS is to support folks who are providing that kind of counseling without those colleagues available to them directly.
I think when you're moving to whole exome sequencing, having that genetic counselor available in particular is so important because you often get back results that fall outside of your wheelhouse. So
Absolutely, absolutely. And even I think the way that genetic counselors can explain just genetic findings, genetic testing, it is just a gift to the family as well. So I think there's many reasons, both for the specific expertise of a disease, but also just the nature of the test. It can be very helpful.
and these multidisciplinary clinics are so helpful, but even just developing those relationships, if you're someone who wants to see patients with immune deficiency, knowing the rheumatologist you can reach out and the oncologist and the endocrinologist that you can ask questions to can be really helpful as well. So building that resource behind you.
Yeah, absolutely. And I think one of the for folks in private practice, or for folks at institutions that don't have as much immune deficiency expertise or genetics expertise, I think one of the amazing things in our field is our regional societies, and really leaning into your regional society and the network of local tertiary and quaternary care institutions that are available for either formal or informal consults or referrals. There's definitely lots of groups like the Dysregulated Immune Response Team that are spread around the country and do the exact same kind of work and can serve as, regional and national referral centers, or even just, knowing who to email for advice and whether it would make sense to refer. But our regional societies, I think, do a great job of bringing folks together, and then it's easier. There's always a lower activation energy to reach out to somebody you've met before. So I think taking the opportunities to go to the Quad AI and taking the opportunities to go to your regional meeting are a great way to know your local network of folks that can support you in our field.
That's great. I would love to ask you a few questions about the work you're doing in your lab. I know you
Sure.
study T cell dysfunction as it relates to primary immune deficiency and other chronic inflammatory diseases. Maybe I would love to hear a kind of high-level overview of kind of what you're working on right now.
Yeah, absolutely. Thank you for asking. Our lab studies how chronic inflammation affects T cells. And we look at that two different ways. One is to think about how chronic inflammation that's environmental affects how our immune system works, and that's looking at obesity and obese asthma. And so earlier in my training, that was the major focus of my work, and now it's kind of what about a third of my lab looks at. And that includes studying pediatric patients who deal with obesity, as well as older adolescents who receive bariatric surgery and how that weight loss affects their immune function. And we also study mouse models of those diseases. The majority of my lab studies how genetic causes of chronic inflammation affect how T cells work. And why do we do that? The diseases that our incredibly rare and complicated patients have are a way to understand how these proteins affect immune function in people as opposed to in mice. And mice and people are very, very different. And so what we try to do is find questions in people with rare immune diseases and then understand how those cells work differently in those diseases, and then expand that out to help us understand the immune system as a whole, but also how to take care of our patients and how to understand our patients. So for example, we study the way that our immune system gets alerted to chronic inflammation is generally through cytokines, different proteins that float and provide signals that are inflammatory or anti-inflammatory to our body in many ways, but in part they affect our immune cells. And so we look at primary immune regulatory disorders, but there's still, more than 100 of those. And so we focus in a little bit more than that and look at the immune regulatory disorders that to some extent look kind of like obesity in that they are chronic inflammatory diseases. And what do I mean by that? So the STAT1 and STAT3 gain of function as examples turn up the way the body responds to cytokines in the blood and also lead to more of those cytokines getting released. And so there's kind of a positive feedback loop of I am exposed to more as an immune cell of these inflammatory signals. And because of the genetics of the cells, I produce more of these inflammatory signals. And so the system gets in a reinforcing loop. And so we've studied multiple immune regulatory disorders and found that in different disorders, different parts of metabolism, so like the biochemistry that underpins the biology, is tweaked and makes the situation worse. Instead of helping to turn that rheostat of inflammation down, these are often fixes where the body has landed in a place that is less adaptive and less optimal than you would hope it would be. And that may provide us new targets to target the metabolism of our immune cells as an additional strategy to treat our immune dysregulation disorders.
So it sounds like your research really informs your clinical work, and kind of your clinical work informs your research. This kind of
Absolutely.
perfect model of bench to bedside and back.
Yeah, I'd always hoped for was that the two would reinforce each other. I think it's incredibly hard when we reach the limits of what medicine can do for our patients. It's incredibly hard. And when we can then at least walk to the lab and say, okay, this is a question that needs to be brought to the bench. What can we learn in the lab to try to better understand this limitation of our current medical understanding or medical treatment options, and then bring that back? The other thing that I think medical practice has taught me that I really am focused in on lab is that, it's a fairly, if you say it to someone not in our field that, oh yeah, we take care of 500 diseases, like it sounds kind of crazy. And the reality is we take care of 500 incredibly rare diseases, right? And so not only do we need to know how to diagnose them and identify the patients, we need to treat our patients, right? That's why they come to us, is to get treatment. And there's there's no way that there's going to be pharmaceutical companies that will be able to make drugs for each of those disorders. And we've already said out loud that the different variants of the different variants in one gene can be wildly different from each other. So there's definitely not going to be anytime soon, although it'd be incredibly exciting, variant to variant level treatments. And so one of the main focuses of our lab is it's really fascinating to look at these diseases in isolation and really understand what happens when you change STAT3 signaling for a CD8 T cell and how you can fight infection. But also, if you pivot and say, you know what if we just look for shared functional problems and how these cells work? And instead of being as focused on which gene difference you have, we say, okay, well, these CD8 T cells fail to work in a shared way. How can we target that dysfunction? And that's the thing we're fixing, right? And so people like Roshni Abraham, who are developing these CLIA approved function tests, the more that research can lead to the development of functional tests that can identify a dysregulated system that we have a tool to use to re-regulate, to retune, that may be another strategy for our incredibly rare diseases that both increases access, because you don't necessarily have to have a genetic difference known. You can say, well, this pathway is out of whack, and then I have this way to tune it back up. And we are not there yet, but I think that's really an approach that's becoming very popular in our field, to think about pathway level dysregulation and dysfunction, and how do you retune those pathways with the drugs that we have, both because it helps us build clinical trials amongst multiple disorders that are each very rare, but also because it helps us take care of our patients when they're well and when they're sick, if we think about sort of the logic of the basic science of their cells and how they're working.
I think the phenotypic evaluation of patients and really being able to say what we need to address from a clinical side is so important. We're seeing it in asthma, we're seeing it,
Oh, for sure.
in immune deficiency, we're seeing it in all these places where now we have such targeted medications. If we can pick out these phenotypic differences, it really allows us to treat our patients well, and more specifically.
Absolutely. I mean, we were really have a really fascinating mouse and human study looking at obese asthma, where there's a number of patients with obese asthma who are type 1 immune skewed, but a number that are type 2 immune skewed. And in asthma, as you highlighted, until we got to the point from a trial basis where we focused on type 2 and non-type 2 patients, it wasn't possible to identify biologic therapies that would be efficacious. But clearly, that insight alone had been transformative for asthma. And I think it's the exact same thing in immune regulatory disorders. If cells are absent and one requires transplant very early, that's very straight. It's its own challenge on many levels, but diagnostically it can be more clear. When you have differences in function and the system is not properly regulated, you really need to understand what functions are not in proper balance. But it's the same idea. If you can find the right endotype of patients, then you can apply the right targeted therapy. And so I think that's exactly where our field is, for inborn errors of immunity, is what are the functions we want to be measuring? What's the right way of measuring them? And then what treatments do we bring to bear for those different kinds of dysfunctional states?
And you won the Quad AI Foundation Faculty Development Award in 2018, which was so exciting, and then won another Faculty Development Award recently. How did that contribute to your work? And importantly, today's scientists, these young scientists that are coming up, what advice do you give them as they pursue making our field even better?
Yeah, absolutely. I'm incredibly indebted to the Quad AI Foundation. I think the award that I won in 2018 was around this idea of finding shared differences and thinking about how cells work in different disorders, and specifically how CD8 T cells fail in a couple of these more inflammatory PERD-like disorders, and trying to understand those differences. That money allowed me to study those questions with a technician that was in my group, and I got that award right as I was about to start my lab. So it was transformative to be able to hire another person to help me get the lab started and to collect that data and pay for those experiments. So it was so important for getting started, and I think such an insightful, nuanced strategy to support pipeline, to think about when exactly folks need that amount of money. So important, and really led me to get involved and stay involved in Quad AI. So since then I've been on committees, and I just came off being committee chair for the GMBE committee, because I think it's an incredibly important organization that supports our trainees. And then the new award is really built towards helping people transition into R01 funding from, you have an independent group, but you're moving into being R01 funded. And I think that award was also transformative for me. There's definitely a moment where you're coming off of your early career awards. So things like KO8s and K23s or Boroughs Welcome funding that really helps you get started, but then ends after about 5 years. And then if you haven't yet transitioned to R level funding, it can be very hard to bridge that gap. And so I think the foundation award that I received this year was also, tremendously well timed for me and well thought out as a new mechanism. So I'm just incredibly grateful to the Quad AI Foundation and to all the folks who put time into fundraising and into reviewing applications. I think it's also a great way of bringing our field together when the foundation dinner happens every year to hear about the amazing things that young trainees are doing and to gather and honor the importance of research in our field. All of the intellectual capital that goes into insights that lead to the development of drugs that treat our patients requires basic science and translational science and clinical trials and epidemiology. And to honor that and bring those folks together is really beautiful. I think for our trainees, for folks who are looking towards incorporating research in their career long term, I think there's such an important role for actually even the regional societies, the small grants, like $10,000, $20,000 grants that you can get from your institution or your regional society makes it possible to be a good applicant for something, the larger grants like the Quad AI Foundation grants, which then make you a much better candidate for your K award. And so there is kind of a cascade of, if someone has funded you, it makes it easier to get further funding. And so I think that CV element is so important. But I think also just attending the meetings, the new discovery track we've had over the last 2 years has been just a wonderful addition to Quad AI. I'm trying to bring in more basic research and more PhDs and MD PhDs to join us at Quad AI. And I've really enjoyed being a part of that working group with some of the other folks we've had on the podcast, like Carrie Sokol and other folks who are part of the planning committee. I think there again, just coming together with your community and talking about the important questions, learning about new techniques drives your own work forward, and I think inspires folks to stay in the field.
Yeah, I think Carrie, who I had on earlier, talked a lot about just the importance of building that community because research can be somewhat of an isolating, you know, world where you're really working on a very specific project, but having this community around you that you can bounce ideas off of, hear about what other people are doing. So I think the discovery program is great. And I love hearing what our upcoming scientists are doing at the Quad AI Foundation dinner because it's so exciting to see where they're taking their career.
Oh my gosh, yeah. I for like Carrie and I met when we were both do postdocs at a conference and have been like friends for, oh my gosh, I guess it's more than a decade. But that came out of a conference and out of it, a research experience. And I have another colleague, Don Newcomb, who used to be the chair of GMBA. We met going ice skating at a Keystone meeting. Like you build your community of folks in training, you build your community of folks at meetings, you build your community of folks that support you and that you learn from and that you teach. And it really does drive any career forward. But I think especially research and medicine benefits so much from having a big network of people both to learn from and to be supported by and to support.
Absolutely. Well, thank you so much. I think this was a fantastic episode for people to really hear about the power of genetic testing in their patients. And I hope they will reach out if they have questions to the experts in the field, because I appreciate you and so many people that spend the time to do the research to really understand the underpinnings of the immune system better.
Oh, absolutely. Thank you so much for asking. I think it's such an important topic. And I think as I've been told by so many people who have trained me, like I'm always happy to talk to anybody who wants to talk about any of these topics anytime. But thank you so much for the invitation. It was really fun to chat.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists and immunologists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at the Quad AI website. Please visit quadai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through whatever podcast platform you use so you can receive new episodes in the future and to leave a review. We're always interested in feedback or recommendations on future topics from our listeners. Thanks again for listening.